morning and
let me welcome you to this session, and I know Dr. Mithun is a good speaker. He is from AAG. I request him to speak on indications for a liver transplant and pitfalls in a MELD scoring. It's over to you, Doctor.
thank you, sir. Thank you for the kind introduction. And so my job is in this complex scenario, as I have heard, my job is a little simple because I'll be talking about the basic indications of liver transplant, which in this August gathering, I think everyone is aware of it. So this is the outline of my talk. The first is when to refer and list for a transplantation. How are the different types of MELD scores, the MELD sodium, the MELD-3 are used? What are the limitations, and can we make the MELD score better to select our patients from getting denied of a transplant? So first of all, when we know that when we talk of referring for a transplant, there are always some triggers as a clinician. So the book says, the first episode of decompensation, please discuss with the patient and try to put him in a center where transplant program is running. The first episode can be either the presence of ascites or a variceal bleed or an encephalopathy. Or if somebody has a rapid increase in the MELD score, or a patient who is getting admitted with recurrent episodes of infection, the moment you start diuretics, he is going into renal failure, or he has encephalopathy, and if the patient has become very malnourished, frail, or he see that his muscle mass is getting lost, this is a part which we hardly discuss. These are the triggers as the clinicians where we should start thinking of referring to a transplant center. Now we should also keep in mind that you should assess the transplant benefits. It's not the MELD score alone. Sometimes you need to assess the reversible factors like alcohol use, infections which can be treated. And there are many patients, this holds good more in the Western countries than in India. The living donor transplant can be used in situations where MELD is under prioritizing it, but you feel that a transplant is required. So the broad indications of liver transplant are acute liver failure, a patient of cirrhosis who has decompensated, the malignancies, metabolic disorders, and some of the systemic complications of chronic liver disease. Of this, the most common indication still remains as cirrhosis of liver, covering around 57%. When we talk of acute liver failure from India and the acute liver failure from the West is totally different. As you see in the Western countries, it is mostly acetaminophen related acute liver failure, whereas in India, the majority of the ALF are actually Hep E related, and this is data from the All India Institute which says that in majority of the patients, of the 40% patients where you don't know the cause of acute liver failure, if you do an E antigen, you might find them positive. It accounts for 5 to 6% of all the transplants that are done in the country. In some countries, it varies between 8 to 10%. The second indication of chronic liver failure, the only thing I like to highlight here is that NASH, that is MAFLD, is catching up with alcohol-related liver disease, which is becoming one of the very complex cause of doing a transplant, because most of these patients with MAFLD will have metabolic syndrome, they will have diabetes, they will have chronic kidney disease, and this leads to a very complex scenario pre-transplant as well as managing them post-transplant. The next indication is hepatocellular carcinoma. As the introductory was told that you will be discussing about operating within the criteria and outside the criteria. Most of the time we are familiar with this criteria, but now with more and more complex cases coming, borderline cases are taken up for surgery, and we see that the results are not that bad, but we still stick mostly to the Milan and the UCSF. There are some surgeon-friendly criteria, there are some hepatology-friendly criteria, and the debate goes on. There are other malignancies of the liver where a transplant is indicated. These are rare indications. There are cases where a transplant has happened for hemangioendothelioma, for a neuroendocrine tumor primarily of the liver, which is very rare, and of course in the pediatric population in hepatoblastomas. We also have a very controversial and debatable indication, which is cholangiocarcinoma. We are all aware of the Mayo protocol, where you select a patient who has a lesion of less than 3 centimeter without involvement of a lymph node, give them a neoadjuvant chemoradiation, and then if you do a de novo transplant, you have a 90% survival at 1 year, which boils down to around 50% by 10 years. But we need to think beyond this, whether there is a role of bile acid circulating DNAs which can be helping us in selecting more patients, or whether we can do some post-surgical chemoradiations which can possibly help us in getting better results. The next indication of a liver transplant are the metabolic and the cholestatic disease. Many of these are pediatric patients with biliary atresia. It's done sometimes in many patients with Wilson disease where the results are excellent. And then there are the rare diseases like hyperoxaluria, where we can be cured by transplant. There are some other conditions where transplant may not be curative, but may improve the outcome, like those in some of the glycogen storage diseases. Apart from this, we also know that patients with vascular diseases of the liver, like Budd-Chiari syndrome, where you fail a TIPS or a stent gets blocked and it becomes non-recanalizable, these are the patients who are taken up for transplant. We find in our clinic a lot of time people coming worried about cysts in the liver. We tell them these are benign cysts, but many of the time they have large polycystic liver diseases. If they are very small, you can handle the dominant cyst by an aspiration or a sclerotherapy or by a laparoscopic fenestration. But when there is a massive polycystic liver disease causing malnutrition and causing complications like pain and affecting the quality of life, this is one of the offbeat indications of liver transplant. In a gastro setting, we get a lot of patients sometimes of Caroli's disease who presents with recurrent infections. The smaller infections we can treat with antibiotics and UDCA, but if it's a bilobar disease, or if there is any debate about the development of a malignancy, these are the cases we take up for a transplantation. The last two indications are primary biliary cholangitis and the primary sclerosing cholangitis. PBC, we normally try for a transplant when the patient is decompensating with a high bilirubin and with a low albumin, and intractable pruritus is one of the indication. Any patient, young patient of primary sclerosing cholangitis, we need to keep in mind that the MELD score usually do not give them much credit, but the Mayo score can predict the outcome. Finally, I touch upon some rare indications. One of the indications is amyloidosis. Few days back, a patient of renal amyloidosis came to the clinic asking for a liver transplant. So we should understand that amyloidosis liver transplant works only in one variety, that is hereditary transthyretin amyloidosis, and if there is familial amyloid polyneuropathy. But the crunch here is that if the disease has advanced, it doesn't reverse the amyloid deposits. So you have to do it early. Most of the time, it is the neuropathy which reverses, and the 10-year survival in these patients varies between 50 to 70%. There has been reports of transplantation in hepatic sarcoidosis, which is one of very rare indications. Now I move up to the second part of my talk, which is the MELD score. As you know, the MELD score has evolved from the MELD to the including MELD sodium, and then in 2023, they use gender. But there are a lot of things the MELD score doesn't take into consideration. Refractory ascites, GI bleed, all these are considered to be out of the MELD criteria. Neither does it take into consideration the hepatopulmonary syndrome or the portopulmonary hypertension. Also, there are conditions where the MELD score may not be useful, like in cholangiocarcinomas or patients with Budd-Chiari syndrome, in patients with polycystic disease. These are conditions where the liver function remains well preserved and the MELD score won't help us. So what has changed from MELD to MELD sodium to MELD 3? As we know, the MELD was initially used to for prediction of outcome of TIPS. It was included bilirubin, INR, and creatinine. The MELD sodium thought that we need to include sodium, and the MELD 3 had included the gender so that it feels that it can change this. The aim was that we have a better mortality prediction, and this policy was adopted by US in 2023. Now, I come up to 3 or 4 pitfalls of the MELD score. The fallacy number 1 is creatinine is neutral. That is the biggest fault, because creatinine underestimates the kidney function, particularly in women, because they have a lower muscle mass. So they will have a lower MELD score or a MELD sodium at the same risk. Now the national data has shown that the worst waitlist outcomes for women are similar at the scores, and MELD-3 possibly partially corrects this. The implication is that we should move towards something better like measure GFR or consider it for the height and the body size, and we should advocate earlier transplant in these patients. The fallacy number 2 is that we believe one size fits all. It doesn't. For example, the MELD sodium underestimates the mortality and morbidity in PBC and PSC. These patients may be having recurrent cholangitis, they will be having pruritus, which may be intractable, affecting quality of life, and sarcopenia because of the loss of the fat-soluble vitamins also. So this MELD score will underestimate this. So we find that there is a higher waitlist dropout despite a modest MELD score. So we may need exception pathways for these patients. The most important fallacy that we find here is that ACLF patients' risk is not captured by the MELD score alone. ACLF has much higher short-term mortality than predicted by the MELD sodium. So possibly a CLIF ACLF score will outperforms the MELD score for predicting the 30-day mortality. We can use the ACLF grading or the scores along with the MELD when triaging these patients for liver transplant. Finally, we take the lab parameters. So lab-only prioritization ignores frailty. Frailty or sarcopenia is one of the most major things which is affecting the outcome of this patient. We see most of the patient, by the time they come to our center, their muscle mass are lost, their bellies are out. So we need to include this as an exception, particularly in low mission. So we should incorporate the liver frailty index or the hand grip strength into listing decisions. And finally, there is a lot of interlaboratory variability in the INR which can shift the MELD score and the position. Exception points like ACC may distort the sickest first if the policies are not clear. Even a small ACC makes it on the top priority. So we should standardize lab parameters, and we should have a diagnosis-specific exception guidelines and include the patient as a whole. How can we solve these problems? We may try to use MELD-3 for baseline priority. ACLF-specific models like the CLIF score or the ARC score can be used to capture near-term risk. Frailty metrics and sarcopenia measures should be used. And disease-specific modifiers like cholestatic disease, refractory cholangitis should be considered as transplant exceptions to the MELD score. And whenever there is a gap of option of not getting a cadaver liver, a living donor options can be used to overcome these problems. The contraindications of liver transplant now still stands as relative at this point of time, though normally we don't take patients with raised ICP in acute liver failure or with advanced cardiac pulmonary diseases, but this is something this conference will possibly discuss because these are where the controversy lies. And there is no age cutoff which I feel nowadays. There are people who want a transplant at 70 years. So Chairperson, with your permission, the final take-home message is that the indications of transplant remains decompensated cirrhosis, selected ACC within criteria, acute liver failure assessed by the prognostic criteria, and the other diseases we mentioned. MELD is necessary but insufficient. It misses sex, ACLF, frailty, and disease-specific risks. We can use MELD-3 plus adjunct scores and use structured exceptions and advocate early transplant for women, ACLF, and cholestatic disease. And whenever feasible, consider living donor liver transplant to avoid a lot of waiting list attrition in the cadaver list that we always see. Thank you so much. I'll be happy to take any questions.
Yeah, thank you, Dr. Mithun, for an excellent and lucid presentation. You were specific to the topic given to you. Uh, yeah, you mentioned some of the rare indications like sarcoidosis, etc. But in them, you feel that liver failure should be a component. That is the one clarification I wanted to know.
Yeah, liver failure should be there, but I said this is just last week. One patient from I think Delhi, he came with an information that if you do a liver transplant, he is a CKD patient. He has been told that his kidney will get normal, so the nephrologist referred to us, but he didn't have the specific type of amyloidosis. So as of now, we have not transplanted any case of non-liver indications where liver failure has not been there in amyloidosis.
Yeah, some of the, of course, a list will be much bigger, but some of the indications where liver transplantation had been done, like a dengue fever with a liver failure, also COVID-19 with a liver failure. Of course, it's a long list, but anyhow, thank you. And some of the limitations which you have told in a MELD, definitely there are some fallacies. The parameters this MELD takes, like creatinine, etc., so many influences, including the way we do it. I think those make a difference. But ultimately, idea is that a sickest patient or a patient who needs it more should get a priority. That is the message I think you wanted to give you. Thank you very much. Dr. Srinivas, you have any comments? Or I will open some of the comments from house. Dr. Sharat?
Yeah, thanks, Mithun. So I think we have to, there are multiple problems with allocation. Srinivas, we talk so much about MELD, and it doesn't really capture the sickest patient. And some countries have moved on, as you might be aware. UK is using NLOS now, liver allocation system, where they take multiple things into account. They take the donor condition into account as well. So people are moving on with MELD, and it needs to be modified. But unfortunately, I think in our state we are still stuck with a lot of problems. Even getting a MELD exception approved is also a difficulty. I think we're having a lot of practical difficulties. So I think it's good to discuss MELD, but a lot of times there's a lot of sarcopenia, there's encephalopathy. There is a patient who's been admitted several times to the hospital with a pneumonia, for example. It just doesn't get captured anywhere in the MELD. Decreased effort tolerance, so many other things. I think there's so many other things we need to consider in addition to MELD. And ultimately it comes down to the treating team. There has to be some guideline, I accept that, but within a given range of MELD, maybe 3 or 4 points here or there, there's so many other factors to consider. Quickly about amyloidosis, we actually operated on a patient with amyloid a few years ago. We planned a domino transplant, but unfortunately due to difficulties and a very prolonged cold ischemia time, we could not use the recipient's liver to do the domino transplant. So there were some technical difficulties with that surgery. But yeah, we did attempt a domino for an amyloid patient.
Thank you, sir. Thank you so much. Yeah.
Thank you, Dr. Mithun. I think that was an excellent talk. I just wanted to extend from what Sharat was saying. Basically, I mean, MELD, the allocation criteria, they're all a way of assessing the relative urgency of transplantation in a cadaveric waiting list. I mean, in India, 80% of transplants are done for living donor. And I think here we need to really look at the patient benefit. You know, what is the risk benefit for the patient rather than just looking at what's the MELD score and related to other patient waiting list. So just to generate a discussion, I'm asking, do you think we should have separate listing criteria for LD, LT and DDLT?
Yeah, so first of all, I feel even our hospital, individual hospital doesn't have a list which is based on severity. Let us be honest about it. So in India, it's like, it's my relative's liver, it's my money, so you do it. Even if he's 72, he is valuable for me. So we definitely need some criteria for living donor, definitely, because all these criteria are criteria based where the organ is a state organ. So in India, we hardly get a state organ, so it's mostly your personal organ, or the wife or son. So we do think at one point of time, at least at a state level and then at the national level, we need to have some criteria for living donor, because we are possibly the highest in the world doing living donor transplants from other 1 or 2 Asian countries. So I agree to that.